We're now back in session. Rajiv Shah, a good friend of mine from India, will be talking about neglected calcaneal fractures. Thanks.
Hi, Selene. Hope my screen is seen and I am audible to all of you. And thank you very much, Selene. At the outset, you have been a good friend and a mentor. And I do recollect our days where we had started with Indo-US foot and ankle courses, and then we had been to the Africa for African foot and ankle courses. And uh, I'm going to take over onto neglected calcaneus fracture, and I'm very happy to have a big time panel with us. We have Professor Chua, who is the professor at Sunway Hospitals, Malaysia, and the chairman of Malaysian Orthopedic Foot and Ankle Society, and the vice chairman of Asia Pacific Orthopedic Association. And we have uh, our next esteemed panelist, Professor Arvind Puri. He is practicing foot and ankle surgeon at Cairns, Australia, and present chairman of Asia Pacific Foot and Ankle Council, a branch of Asia Pacific Orthopedic Association, and a very dear friend. Welcome, Arvind. And
Thank you.
our next esteemed panelist is Professor Andri Primadhi, who is working as foot and ankle surgeon at Hassan Hospital in Indonesia and is a present president of Indonesian Foot and Ankle Society and a very dear friend. Welcome, Arvind. And last but not the least,
Thank you.
we have Professor Kwai Ming Siu, who is a very good friend and a master trauma surgeon, immediate past president of Hong Kong Foot and Ankle Association and past president of Hong Kong Foot and Ankle Society. So with this esteemed panelist, we are going to start with the presentation of the cases, and I'm going to seek opinion of this expert panel. This was a male of 50 years who sustained fall from height and arrows due mark to a calcaneus fracture. This patient was treated with plaster, and it's now about 2 months and 2.5 months that he comes to us for the follow-up, and he do complain of pain and difficulty in walking, swelling. These are the x-rays at presentation. Another x-ray. Now this is the x-ray axial image at presentation. It is like 2.5 3 months, and these are the movements, and this is the way he walks. Videos are working. 2.5 months old malunited calcaneus. How would you manage? Arvind, your viewpoint, please.
Thank you, Rajiv. Certainly a difficult case and more difficult for the time period. So 2.5 months, and I'm assuming on the CT scans, you have seen some sort of union which is progressing satisfactorily, or is it non-united? So it's not really united.
Yes. You
And
want to
he's a
see
50.
few more CT scan?
Yeah, please, just to see if there's any hint of union at all.
So now,
Yeah,
would you
so
reconstruct or would you fuse?
So I personally, he's 50 years old. It is quite a, it's almost like a Sanders 4 kind of a fracture from the CT scans that I can see. And I would be more inclined to offer him a primary subtalar fusion.
Okay. Professor Chua, your viewpoint?
Yeah, okay. So it is patient at 2.5 months, where he have a varus calcaneum. I'm sure when he walk with a varus foot gait, which must be corrected. and there is a depressed intra-articular joint. So whether we want to give them a little bit more subtalar movement, or you want to fuse them. Of course, in my patient at 2.5 months, it's still possible to do the salvage procedure by opening up the lateral wall, and then you can see the depressed cartilage on the posterior facet, and then you can still do some osteotomy over that side to elevate the joint and also put some bone graft. But more importantly is a varus on the axial view of the calcaneum, which must be corrected. Whether you do fusion or salvage procedure, this must be corrected. But in this patient, 2.5 months, maybe it still can give him a chance for salvage procedure.
Professor Andri, would you reconstruct, or would you fuse?
Yes, thank you, Dr. Rajiv. I think we can list some problems here. First is the malunited fractures. You can see the decreased calcaneal height and also the varus deformity with the impingement of the lateral side of the calcaneal. And also about this, because this is more than 2.5 months, I think there's some stage of arthritic already happened in the subtalar joint. So for this patient, I will choose fuse, but not only the subtalar fusion, but also the corrective subtalar fusion. That's my view.
Professor Kwai Ming Siu, your viewpoint, please. Would you reconstruct or would you fuse?
I would like to suggest a reconstruction in view of the patient is quite relatively young, 50-year-old, and also is a type 2B Sanders displaced intra-articular calcaneal fracture. And yes, there are shortening, widening of the width, and also varus deformity, but that's, the fracture has not united yet. I think I will give the chance to reconstruct it rather than fusion.
Okay. So what I did fusion and reconstruction of the fracture to the best of the possibility, and did a primary fusion. Professor Chua, your opinion, please. You have done it differently. Why? And your comments onto this. Because you want to reconstruct it. Is there any limit for you where you, beyond that, you don't reconstruct?
I think more importantly is to discuss with the patient on what the patient expect. If you say that it is a mutual discussion between the patient on whether he want more joint movement. Of course, if you salvage, how much of movement you can give him? Maybe just like a fusion restricted movement. But in the 2.5 months, I've done a few, which is still possible to reconstruct the joint and give them a little bit more subtalar movement at this age. And of course, you have corrected in your patient, you have corrected the alignment to the neutral rather than the varus calcaneum. This is very good. In the AP view, weight bearing, I would say that I will let the lateral wall to a little bit less because not so clear here. I'm not sure your lateral wall is still have some subfibular impingement or not on the AP view. Yeah.
Okay.
Rajiv,
Yes.
can I ask you what approach did you use for this?
So I used extensile lateral approach for this patient, because for the all delayed presentation, I would like to use extensile lateral approach unless I have to jack up the height. We will leave this discussion for a few moments here, and I am pushing to uh, uh, another case. This is the case of my close friend and a big trauma surgeon, Kashyap Adeshna. It's a 4-month-old neglected fracture which was poorly managed, and uh, this is how uh, it was uh, managed. Thus, almost a similar case, 4.5 months, neglected fracture, and these are his CT scan. Uh, this is one image. This is the another image. 4 months, and this is where now, Professor Kwai Ming Siu, what would be your management? And then I will come back to Professor Andri also. 4 months old, neglected, poorly managed calcaneus fracture. Again, in a young patient.
I think there's a the malalignment of this fracture, say a loss of the bolus angle and angle kissing, pelvis heel, and for me, I will I, the subtalar joint is still not in, not is intact, not involved. So I will to realign the calcaneum to restore the bolus angle, the angle cushion, the height, and also correct the pelvis deformity. And also, I expect bone graft is required for this case and put in a plate. May I have a more view about the articular surface of the subtalar joint?
Articular surface of
It's
subtalar joint.
still smooth, okay? Yeah. Okay. I think that is still joint space of the subtalar joint. So it's a triarticular type of fracture. How about the CCJ, calcaneal joint?
CC joint is not involved.
Okay.
It is not
So
involved.
it's triarticular type of fracture with a non-urine and also breakage of the plate. So we are like to make reconstruction to restore the cover the pelvis, the height, and also the length of the calcaneum with bone graft. And also, I think we should also exclude any infection. I think whether there's a still, it seems there's some bone resorption around the fracture site.
So, Professor Andri, are you for reconstruction?
Yes, I think we can see this from the CT scan that the posterior facet is still relatively good. So I will choose to remove the plate and then do reconstruction, correct the varus deformity, and maybe do some grafting and do the fixation using several screws.
Grafting, grafting, cancellous grafting,
Yes.
or grafting from where?
I think we can, because the calcaneus is a big cancellous bone. I'm not sure if there's still a non-union or a malunion, but after we do the osteotomy reconstruction, if there's still a gap after we do the reconstruction, we can fill just for bone filling, maybe not autograft or something, but like a synthetic graft for bone for void filling. My view.
Arvind, do you think that you would be able to get out without some kind of a real, solid bone grafting, or you would be just able to get out with synthetic graft or a cancellous graft?
No, I think, Rajiv, this is mostly extra-articular with two problems. One is the varus deformity, and the other is the posterior tubercle is proximally shifted. He's already 4 months. I personally would wait, let it all heal up, then come back, take the plate out, do the corrective osteotomies, and use a tricortical solid graft to get him. So like doing a lateral wedge to correct the varus, and then slide that posterior tubercle down and fix them once again purely extraarticularly. And I think that's what I do. But I would much rather wait for this to heal fully than I can do my osteotomies where I want them to.
Professor Chua, any other view?
Yeah, this must be corrected because it's a varus is a problem. So you can do a crossing wedge osteotomy to let the lateral column slightly shorter, which will not affect so much of his function. So with the short crossing wedge osteotomy from the lateral side, then you may not need a lot of bone graft.
So we thought that we should not shorten the calcaneus, and so the plan was to do double trapezoid iliac crest grafting, and implants were removed, pseudoarthrosis was identified and excised, and uh, the whole mobility of the heel was established, and tricortical wedges plus cancellous grafts from the iliac crest were harvested, and medially based double trapezoidal wedge plus cancellous grafting was what done, and this is how the post-operative pictures looked like. Uh, any comments onto this?
I think
Prof. Rajiv, yeah, may I ask why you say that the calcaneum shouldn't be shortened? And for the
because
varus, yeah.
the other side has no calcaneus fracture. When you shorten this, you're reducing the liver arm of tendoachilles. Patient would have a lot of limping, and calcaneus function would also be weakened. So, if you have something where you put in a structural graft and you have a length restored, it is always better. Why to give short calcaneus? Then it would always be better to give the right length. And this bogs down to question to all of you esteemed panelists, that is there a criteria with which you go for reconstruction or you go for fusion? So what all are the criteria for you to decide that you're going to go for reconstruction or you're going to go for fusion? So if we can start with Professor Chua. Like time is the
For now,
criteria for.
yeah, timing. I think 3 months. 3 months, you still need, still able to do the reconstruction, and then of course, if the joint is good and only the varus deformity and the lateral wall that is burst out, then you still can do a reconstruction. But if the patient is the age also a factor. I don't have a clear line on how old is old. Maybe 60 above. Um, then you need to discuss with the patient on what the patient expectation. If you don't mind to have a limited subtalar movement, then fusion will be good. But some patients do not want it to be fused. Then you still can do some reconstruction. Yeah, that's my view.
Arvind, you wanted to wait. This patient already a neglected one who got treated with a bone setter and comes to you, and you still want to wait, because I'm afraid this kind of patients may not turn up again, and they go with a lot of disability.
So I agree. In the social setting where you are not confident that the patient will perhaps follow the instructions that you want them to, then yes, I think it's perfectly reasonable to get them explain, discuss, manage their expectations, and proceed with it. But if the patient comes from a background where you could, so for me, it's 4.5 months now. If there is any evidence on the CT scan that this is healing, I'd much rather wait rather than go down, find the old fracture line, take off everything, then redo it again. I'm much more comfortable coming back, then doing the lateral osteotomy and the calcaneal osteotomy. But I agree with you. If the background and the social circumstances are such that they will be not following the instructions or willing to do what you want to do, then yes, you should and proceed early rather than late.
And going late. Go ahead,
as far
please.
as the question about reconstruction, when do you do that? When do you fuse? For me, it's the patient and the fracture factors. If the patient is a manual worker, I think fusion is the best thing. It's one operation, it lets them weight bear, go back to work early, and doesn't require two. If this fracture is of a combination which will not, whatever or however well you reconstruct it, will give them the desired subtler range of movement. But if the patient is not a manual laborer, is young, has good, no big comorbidities, and is of a fracture pattern that I can construct, then I will reconstruct it. But I have a very low threshold of fusing them first time if I know from the fracture pattern and the patient's demands that they require something which needs them to get on and start living again.
Great. Any quick comment from Professor Kwai Ming Siu, sir? Any quick comment?
Okay, if there's a significant degeneration of the subtalar joint, I think it's a indication for fusion. And also, if the joint is too very comminuted, and also together with some risk factors, say diabetes, poor prognostic factor, say smoking, diabetes, poor health, or some with significant renal disease, and think without control, then I will choose fusion for this group of patients.
Great. So great comments. I will quickly run through some slides onto literature. Literature for a calcaneus malunion, there are 3 papers onto joint preservation, and there are 4717 publications when you search for calcaneus malunion fusion in the literature. Anyways, for the reconstruction, literature says that for young active patient with less than 3 to 6 months duration, and on exploration, if there is a good cartilage and good bone quality, obviously reconstruction would be a choice versus the opposite one. Let me go to case number 2. This is a good story, and I'm sure Arvind would love to listen to this story. Obese female of 32 calls me at the middle of the night from USA and says that she has severe burning and tingling 1 week post calcaneus fracture fixation surgery done in US. And these were the x-rays which were sent to me. And what would be your advice, Arvind? Lot
Well,
of pain.
the symptoms of pain you would expect, because it's only a week since they had a surgery on their calcaneus.
Severe burning, tingling, numbness.
But if it's burning, then that obviously suggests a neurological component to it, which could involve perhaps the sural nerve. So what I would like to know is which part of the foot she gets the burning from. Is it on the lateral side, medial side, plantar side? And depending on where it is, you have to be quite...
Lateral plantar both. Lateral plantar both.
Right, okay.
And this is the information we have.
So
this is the information we have.
So it might be unfortunate to... So no blocks, no popliteal blocks or anything given to her?
No. Do you think that this big implant and the way this implant has been put in must be the reason for the same?
Well, if it's in a particular distribution, which corresponds to a certain nerve, like the sural nerve or the posterior tibial nerve on the other side, then I think you have to be suspicious of whether this is surgically related or not. Whether this implant itself is doing something to the nerves is, yes, a consideration. But I would be quite keen to know exact mapping of where does she get the burning pain.
Well, so she had tremendous pain. She was crying. She was in agony. I said, better you go back to your surgeon And the surgeon who operated refused that, oh, everything is fine, you continue with medications. But then the next surgeon followed, probably listened to my voice. He did the implant removal. And he said that we will go in again after some time, but the pain, burning, tingling at medial, plantar, and lateral foot uh, was the same. And then the question was, what must went wrong, Professor Andri?
Yes, I think there are several etiology for this kind of pain. I agree that the pain is neurological originated. So other than the size of the implant that can seen overhang, but because the pain is just 1 week after operation, so we have to consider also about the incision, the pain from the surgical incision, and also the nerve injury and the swelling that produce some compressive neuropathy. But after the implant removal, when the patient still feel pain, I think the problem is not only relieved by the implant removal, but also we have to address also the nerve injury that resulted from several surgery that produce some wound at the lateral side that may harm to the sural nerve and or other nerve.
Yeah, so
Thank you.
they went to surgeon number three. He said that because your medial screws are not removed, you have this problem. So medial screws were removed, pain remained the same. Patient in agony used to call me quite often, and I said, look, you need to come down to India to show me. I cannot give you any more opinion on phone calls. And it was exactly after 16 months post surgery, post injury, she comes to India. And these are her x-rays at presentation. This is the clinical picture of hers. A medial incision is not seen because this is a lateral picture. And these are the two x-rays, and to any gaze onto what all are the issues. Sorry, CT is missing here. My apologies for the same. But from whatever available information we have, Professor Chua, what all problems in this calcaneus malunion you anticipate? What all things are gone wrong here?
This case, we may need to do and check the spine whether there any spine injury or not, because
No, there
calcaneal
is no spine
fracture
injury.
10%
No
no
spine.
spine injury.
No.
No spine, only the pure calcaneum. Then you need to check whether there's a complex regional pain syndrome or not for her, and of course
Yes.
the anterior facet that is pointed downward, which may impinge on the plantar nerve. Other than that, I couldn't find any reason why you will still complain of pain. Must be some
Yeah.
impingement somewhere. Yeah.
For Professor Andri, you are to treat this patient. What all problems you see in this X-rays and in this clinical picture for you to address this case?
Yeah, we can see from the clinical picture and the X-ray that the fracture is malunited or maybe non-union is happening here. I think the pain may be originated from the instability of the subtalar joint and the impingement also still possible. And you can see there's some hammer-toeing. Maybe this is also related from the nerve injury. Yeah, difficult case. I think we have to reconstruct. I mean, we have the fusion will likely be needed, but not. We also have to correct the subtalar joint, and then hopefully with the positions, the nerve by decompressed. Hope so.
So, thank you, Professor Kwai Ming Siu. Professor Andri said that the subtalar joint problem, probably a non-union or malunion, clot or deformity. Anything else you also want to add into this? Are you happy with the position of talus in the mortise?
I think there's a mark or decrease in the height of the calcaneum and also shortening, and the talus is in a dorsal fashion, and also there are some hemianal toe. This may due to the nerve injury and the partner nerves, and other possibility may be whether it's associated with the combined syndrome after the injury or operation. So
Great.
may I have any X-ray of the ankle joint, AP, and yeah.
Oh, sorry. Uh, sorry, I don't have these X-rays or a CT scan, but I would make the life easy. So what I encountered that she has subtalar arthrosis, she has talus, which is into dorsiflexion, probably attendoachilles contracture,
Yes.
malunion or non-union of the calcaneus. Heel is into varus. There is shortening of the heel and a sural nerve injury, at the same time posterior tibial nerve injury, and obviously clawing of the toes, some compartment syndrome residues. He also had a lot of pain at the calcaneus, a fat pad atrophy. So uh, these all problems, when it comes together in a calcaneus malunion case, I would want opinion of every esteemed panelist that do you follow the classifications for calcaneus malunion, and what all classification would you follow here for this case? Starting with Arvind, how often do you follow classification?
No, not a lot. I know the simplest one is the 1, 2, and 3, which is perhaps the easiest way to identify the problems, classify them, and decide what you want to do. Whether there's lateral wall exostosis, which you want to remove, whether there's heel varus or valgus, which you want to correct, whether there's subtalar arthritis involved. So those are the simplest way to perhaps in your own mind prioritize what are the big problems that this malunion has resulted in. But no, I don't usually go, doggedly looking for a classification to put the patient's malunion in. I'd much rather have the investigations tell me what the problems are and what I need to address.
Great. So you go with problem-based approach. Professor
Yes.
Chua, this is one classification Arvind spoke about, Stephen and Sanders. It's an axial CT-based classification. And do you follow any classification?
Yeah, I do follow one of the classification, but I forgot the name. He's an author on one of the book. What's it? I've forgotten. So I do follow the classification.
Okay. Professor Andri,
Yes, honestly, not always use some classification. Otherwise, I just identify what the problem is, and then I try to address the problem. Maybe the problem is not single problem and several problems, so I'm just fine and address one by one. But of course, the following the classification is the best one.
Professor Kwai Ming Siu.
I think this is another SIP and Wermo calculation is a more I find this type of malunion in more detail. In fact, for this case, is probably type 3 with a loss of height together with the gravity deformity and also other deformity. So for the treatment for this, I think from the X-ray, there seems that the low lateral translation of the tuberosity. So for this, I will use the destruction bone board subtalar fusion for this case, and this Also, if there's any bulge on the little wall, also need to remove it. Yeah.
So what I have found over years that these classifications are silent onto many issues like nerve issues, soft tissue problems, calcaneocuboid joint arthritis, and so many things. And so they do not speak about calcaneocuboid, talonavicular, and ankle arthritis, nerve injuries, implant-related issues, and soft tissue problems. So the classification which I use, which is an unpublished classification, which is in line to publish, is onto a pain generator based my own classification, which is Adain's classification, where A stands for arthritis. It could be arthritis of subtalar joint. It could be arthritis of calcaneocuboid joint. It could be arthritis of the ankle as well as midfoot joints. And then D stands for deformity, which could be heel varus. There is also a deformity sometimes in form of heel valgus and heel shortening as well as talar dorsiflexion. And then E stands for exostosis, which is most often than not lateral, but you do find medial exostosis in a calcaneus malunion. You also find posterior exostosis, and you also find plantar exostosis, and combination of all this. I stands for implant and implant related issues in a calcaneus malunion cases. And N stands for the nerve problem, which could be sural nerve problem, it could be problem of posterior tibial nerve, it could be mixed one. And then S is for soft tissue problems, where you have a tendo Achilles contracture or a problem like toe deformities, problem like fat pad atrophy, problem like reflex sympathetic dystrophy. And then this Adain's classification tells you to go ahead with problem specific management, which Professor Arvind mentioned here. And to sum up the procedures done in this patient, uh, before I sum up my procedures, we had an opinion of Professor Kwai Ming Siu. Arvind, if you could come up with how would you manage this calcaneus malunion? You have known the problems and what all problem-based solutions you are going to offer to this patient. Please.
Okay.
So,
As
yeah, go ahead, Prof.
Go ahead, Prof.
um,
Prof.
as,
Yeah, go ahead, please.
as, um, so for this case, I will use the discussion bone board subtalar fusion because to correct the various deformity of the heel, also the shortening of the height, and also shorten the length of the calcaneum, and there's a void at the um, body of the calcaneum. So for this, remove all the implants and also put in a bone graft, restore all these deformity in one go. And also for the some hematoma, whether it's a very painful or cinematic, we may need to do some surgery to realign the toes. And also to see for any residual foot numbness or pain, whether we should also do some study, the nerve conduction study to see any nerve problem, and whether we should to tackle this.
Yeah. Arvind, want to add something?
Um, it's a really difficult problem, honestly. The main things here are, as Prof mentioned, is the shortening, the loss of height, the widening, and more importantly, the heel atrophy, along with the arthritis that she's got. So my aim would be to try and correct those deformities, fuse it, but for the heel atrophy, she'll probably require to be having some orthotics in her shoes all the time.
Uh, Anything to be added, Professor Chua, Professor Andri? I agree, this is really the most challenging problem, but Professor Andri could read something between the lines. Yeah.
Yes, I think
And
in some case of the malunited fractures of calcaneus, we have to be sure that what is the source of the pain. Sometimes we are tempted to correct the deformity, to fuse based on the X-ray. We have to make everything looks beautiful, but sometimes we have to understand what is the origin of the pain. So with the correct examinations and so the experience, I think we can understand what's the source of the pain and address specifically. It's my view, Prof. Rajiv.
yeah, so let me show what I did. When I opened up, there was non-union between body and anterior fragment, and there was subtalar arthritis between body and talus. So I had to take in two structural iliac crest bone grafts, which were pushed uh, between body and anterior fragment. They were pushed between, body and talus. I had to go in for open tendo Achilles lengthening to get the height properly. And then I went in, I did the neurolysis and tarsal tunnel release. Uh, and I also did the clotto correction in the same sitting. And this is what was done. Any comment before I proceed to the next case? And believe me, you cannot give fullest satisfaction to these patients. They do have,
Yes.
like this fat pad atrophy, as Arvind stated, was treated with an orthosis. So let me go to the last case before we go for a rapid fire round. A 23 years old male, a manual laborer, had a fall from construction site, had a bilateral compound hindfoot injury. It was managed with debridement and closure for the wound, and fractures were managed conservatively. And it was at the end, it was a 15 days post injury. These were the x-rays. We have to focus on the left side. 3 months when he presented, this were the bilateral x-rays. Let's focus on to the left side. And the left side, this is how he stands on the left side, and this is how he walks. On the right side, he has lost talus and equinus deformity. On the right side, he has malunited calcaneus fracture. And these are the uh, X-ray pictures on the left side. And I'm also going to run through CT scan images. Rotational images, and I am also going to run a video of CT scan image, and it's a very small part of body left out, like you see here on the left side. And so, Professor Chua, what all problems you see here, and how would be your approach to surgically manage this case?
It is the if I'm not mistaken, I saw some subtalar subluxation or something like that on the CT scan. Just now when you went through,
Yeah,
because the picture is quite small, I couldn't really see.
yeah,
Uh,
yeah. Sorry
but
for
I
that.
thought yeah, the calcaneum and the tailor is not in line, I think.
Yeah, they are not in line, as you can
Yeah.
see here in the X-ray picture also, that they are not in line. This is calcaneus is slightly has gone upwards, and it's a very small part of the body.
Mm. The 3D, you can enlarge the 3D.
Okay.
No, I mean the 3D. Yeah. Is it possible to?
This.
I mean the subluxation need to be reduced. Yeah, it look
Yes.
like it's need to reduce and then see whether it's stable or not. If it's not stable, of course you can put some K wiring. But if it's totally not good on the cartilage, then fusion will be the answer on a subtalar fusion.
Professor Andri, what all
Yes, the
problems would
problem
you
is
anticipate when you go for
yes.
subtalar fusion?
Okay. First, the problems we see is some malunion of the calcaneus that producing some deformity that also affected not only subtalar but also will alter also the ankle joint, the tibiotalar joint. But we have to anticipate the problem. As you can see, the first operation is only the debridement and wound closure without doing anything for the bone. So I assume the wound is quite poor, bad at the initial stage at the injury. So we have to know now. I would like to know what's the condition of the soft tissue now, because it
Soft
will.
tissues are stable.
Yeah.
Wound was on a medial side. Soft tissues are stable,
Mhm.
and you can definitely go ahead through the lateral side.
Yeah. So if the soft tissue permitting, we can reconstruct the calcaneus with considering the uh, the pull of the Achilles, and also I think there's some kind of bone loss. So uh, I propose to do reconstruction of the calcaneal height and also the restoration of the axial alignment of the calcaneus, and then do the subtalar fusion with restoration of the calcaneal height. That's my view. And also
Professor,
maybe it's Achilles lengthening.
yes. So, anything to add, Professor Kwai Ming Siu?
I think there's a loss most part of the body and some part of the good tuberosity of the calcaneum. And for this case, there are bone loss. So if we want to restore the calcaneum, I think that we need the autograft, either crest structural graft to restore the uh, height and also length of the calcaneum. And however, there are other problems, say shortening of tendon Achilles, and also after the restoration of the shape of the calcaneum with adipose graft, there may be also shortening, relative shortening of the non-fair tendons, and also need to pay attention to the neural bundle. We need some release of the tarsal tunnel to release the tension after lengthening of the height of the restore the length and height of the calcaneum. And I think it's a quite difficult operation for this. Okay, to restore the put in the other graph as to fuse the um, subtalar joint. Yeah.
Okay, so let me show you what was done. Uh, Open tendo-Achilles lengthening and a small incision for subtalar fusion. This is how tendo-Achilles lengthening was marked, with the distal cut lying onto the medial side to remove the medial pull of varus. And iliac crest bone graft was harvested, and it was put between the tuberosity and the talus, and the height of the talus was restored, and this was fixed with fully threaded screws. No medial incision was given, and This is how it united. Uh, uh, Arvind, your comments onto that. I did not go medially like Professor Manson to release the tarsal tunnel. Your views onto this fixation, your
I I
comments, critical comments.
I I think it's a very well done job, Rajiv. But for me, the big question would be: did you have to deal with anything in terms of preventing infection, or if he had a wound problem, did you have to do anything before?
No, he had healed wound. His other
Okay.
side where the talus was lost was very badly healed.
Hmm.
But I
And
still
now,
was not happy. I still was not happy with my fixation. Professor Chua, would you have done something different than what I did?
Yeah, I think I I will not use the screw so long because it look like it go into the anterior side, which may cause the anterior ankle impingement. And also I will use the cannulated screw, the headed screw, or if you don't have headed screw, you may need to bury the head of the screw underneath the bone, because of the prominent screw, he may cause pain when he wearing shoe and also when walking in this case.
Yeah, I was not happy because I did not fuse all three subtalar joints, which normally is said to be we should be doing for a post-traumatic fusion. Uh, so, how often all panelists do you put in an anterior Rogerman screw for calcaneus malunion cases?
never, just the posterior facet.
Just a post. Yeah, this screw helps to gain the talar plantar flexion also. Professor Andri, you do put this screw?
No, if we yes, sometimes I use the anterior screw, just two, one anterior and one more screw and the posterior facet. But if I use two screw for the posterior facet, I don't need the anterior the ones.
Uh, Professor Siu, from where do you take this structural graft if you require?
Okay, I usually take it from the added quest on the same side. Usually, most of the time, patient in line, if the patient on natural position, I will at the anterior added quest region, which is with a big, very thick um, added quest to a more uh, adequate bone graft, bigger bone graft.
So, Professor Chua, any other site you have used for structural graft?
I normally use a synthetic graph
Yeah. Uh,
to do this.
so many times I use posterior calcaneal tuberosity as a structural graft which is lying very close by,
Mm.
and you can get out without injuring the iliac crest. Uh, and yes, this is one more site for the graft. And such a graft comes and then you can put it into the subtalar joint the way we put it the other structural graft, and this really works well for us. Now it's like 7 minutes to go, and let me go ahead with a rapid fire round. We would be able to take two or three cases. Whatever limited information we have got in these cases, I know I'm dealing with a very, very genius and talented faculties. Please furnish your view onto management of these cases. So this is a case, rapid fire case number one. Male 26, fall from height, injury access. Arvind, this is for you. And this was the presentation at the end of 6 months. Skin condition is good. He got treated by a bone setter, and this is at the end of 6 months that this young man has presented with calcaneus malunion. and the information which we have is that these x-rays skin condition is good, and you have this kind of presentation, a young patient wanting some solution.
So, very quickly, correction of the deformity of the calcaneal, especially the varus, and a triple arthrodesis.
Great. So this is what was done. Calcaneocuboid, subtalar, and the extension of the arthrodesis was done for a talonavicular joint right up to the calcaneocuboid joint. This is what was done. Case number 2 for Professor Chua. Male 25, type 1 diabetes mellitus with neuropathy, had a swelling, unsteady gait from last 4 months, and he is having neuropathy, and he comes to you with this kind of an x-ray at the end of 4 months, where it's a neglected neuropathic calcaneus fracture. How would you manage this young adult type 1 diabetic?
Yeah, so this type of neuropathy foot, we need to see whether after the malunion, is there any abnormal pressure, abnormal extra bone somewhere to increase the pressure when they are walking. If there is, then something need to be done, either by the shoe or surgery. In this case, I think there is a Achilles tendon contracture and also the depressed porous angle, so that the talus is dorsiflex, and all this one may have problem for the patient. So if the diabetic is well controlled at this moment, then we may offer him a distraction subtalar fusion for this patient.
Great, you are an expert and master into that. I also added calcaneocuboid joint fusion, taking this open approach because we wanted a stability, and so this patient ultimately underwent subtalar plus calcaneocuboid fusion. Any comments, quick comments onto that, Professor Chua?
It look great, very solid. As long as is no extra pressure for the patient when they are ambulate, then they will not have ulcer.
Great. This case is for a Professor Andri, a 9 months old, operated subtalar fusion for calcaneus malunion. Patient comes with pain, limp, and disablement, and it is like these are the Broaden's view 10 and 20, 30 and 40. This is how this patient walks with limp and pains. Is a mother of a plastic surgeon, and then you have a failed subtalar fusion for calcaneus malunion. What could be the reasons why it failed, and what would you offer?
Yes, I think we can see that the fusion is quite not successful. Maybe it is a failed fusion. Maybe I think the denudation and the gap is too high. So I suggest to do the take down the screw. As you can see, I think the screw head is protruded to the plantar side. Maybe can be one source of the pain, and also the failed fusion can be repaired with doing some refreshment of the articular surface and put bone graft. Yeah, I think.
Great. So this is what was done. Uh, 3, 4 screws, anterior screw plus 2 bone grafts with lost K wires, and this were the lateral view. So I'm afraid we are now just 80 seconds away, and I'll just like to stop here and convey my esteemed panelists my gratitudes to them, and convey my sincere thanks to Dr. Selene Parekh, who has been my friend and mentor, not only for organizing this fantastic global town hall. I would also like to thank Selene, Professor Chua, Professor Arvind, Professor Siu, and Professor Andri, who are the Asia Pacific giants. Thank you very much. Thank you, everybody.
Thank you, everybody.
Thank you.
Fantastic job.